Okay. Well, welcome everyone. I'm Albert Cheung, a cornea specialist over in Virginia and Norfolk area. I'll be doing an introduction to BrightMEM and BrightMEM anterior keratoplasty. So, we're going to go through an introduction to BrightStar, a little scientific background between around BrightMEM anterior keratoplasty, going over some clinical data, show you a video of the procedure and demonstration, and obviously some time for questions and answers. So here are my financial disclosures. So BrightMEM is a novel corneal allograft that's made from Decimet's membrane. It creates a new foundation for the ocular surface, and it's capable of supporting native limbal epithelial stem cells. It's minimally manipulated donor corneal tissue. It's available from BrightStar Therapeutics and its partner iBanks. You code it under the CPT code for anterior lamellar keratoplasty, and the tissue is reimbursed from the CPT code V2785. So, which patients are ideal for BrightMEM? It was designed with patients with partial limbal stem cell deficiency in mind, but the etiologies can vary in terms of who we've applied it to. And anyone with really a poor healing cornea may be a candidate. So especially those with persistent epithelial defects or really bad epithelium. And so, how does BrightMEM work? So the short story is that it supports a population of stem cells in the basal corneal epithelium. The main tenets of why it works is that it's decellularized Decimet's membrane allograft. The anterior side is able to express some proliferative factors that are similar to the basement membrane of the limbus. And so if you look at BrightMEM and its stromal face, it's the anterior banded side of Decimet. And if you look at these proliferative factors, proteins, Spark, BM40, as well as vitronectin, they're also as well on the limbus as well. And so this can act as a pseudo niche, promoting stem cell and transient amplifying cell longevity. And so the benefits you see are that it provides an optically clear foundation, so a substrate for these new epithelial cells to grow over. It also acts as a pseudo niche, like we mentioned, to promote the stem cell migration and longevity. And then, almost as a cover or shield, it acts as to protect the underlying stroma. Here's some images to sort of demonstrate how it's maintaining the population of stem cells in the basal corneal epithelium. So at the top, you have these confocal images on FOSS. So the image on the left shows a stem cell marker, ABCG2, highlighting in the posterior epithelium, that stem cell marker. In the middle image, you also see posteriorly that you have the transient amplifying cell marker P63 highlighted. And in the anterior epithelium, you can see the mature corneal epithelium that's highlighted. If you look at an orthogonal view, so that's at the bottom image, with the stratified epithelium, anteriorly, again, mature corneal epithelium, and then posteriorly with the stem cell markers. And that's opposed and in contact with the BrightMEM membrane. Another advantage is its resistance to degradation. So here's some images comparing amniotic membrane to BrightMEM. This is with amniotic membrane and BrightMEM exposed to enzymes, so collagenase, with this degradation assay. So the top images show amniotic membrane, and even by 30 minutes there starts to be degradation, and by 8 hours it's completely degraded. BrightMEM, on the other hand, in the bottom images, shows that it persists even at 24 hours in the same assay. So looking at some of the clinical data, I want to first present a case. This is a patient of mine, 24-year-old woman with bilateral limbal stem cell deficiency secondary to contact lens wear. Also has neurotrophic keratopathy. She's plagued by these intermittent persistent epithelial defects, some variable conjunctivalization, as well as fluctuating vision from about 20/70 to 21/50. I performed the BrightMEM anterior keratoplasty with a tarsorrhaphy. Fortunately, the epithelium is healed over the course of the first 2 weeks. You can still see some little bit of late staining, denoting that conjunctivalization or peripheral limbal stem cell deficiency in the periphery outside of the BMAC. This is not you're not transplanting stem cells here, but you're just giving them a substrate to help the epithelial cells that are working. And fortunately, she even a couple months out, she already got to 20/40 vision. If we look at the cases done to date, there's about 140 cases that have been done for a variety of indications of different stems, including stem cell deficiency and persistent epithelial defects of a number of etiologies. 85% of the reported cases have re-epithelialized, and the longest graft to date that's been done has remained clear about 24 months out. There have been no serious tissue-related adverse reactions that have been reported, and a nice observation has been that there's been a marked reduction in pain, as obviously a lot of these patients can have a lot of pain and discomfort from their symptoms like sensitivity and such. And practices and surgery centers have been reimbursed for the tissue without any issue, so that's always an important thing. Here's a table showing majority of my cases to date. As you can see under the third column here, most of them have been done for persistent epithelial defects, most of them in the setting of stem cell deficiency. There was one patient that had refractory corneal erosions, had multiple keratectomies with diamond burrs, but was having weekly erosion still. You can look at the preoperative vision, and most of them have had an improvement. I'll highlight the ones that haven't in their vision. It took about a month to heal for these patients, and in terms of impression, most of these have remained either PED free, so no recurrence of epithelial defects, or if there has been one, it's been a small pinpoint defect that has just healed nicely with just a bandaged contact lens for a week or so. Different than before the procedure. I'll highlight that first patient. So even though she got 20 count fingers, there was a good substantial portion of the time that she was 20/40, 20/70 from her 2200, but there was recurrence of her stem cell deficiency, so limiting the vision. And then the other patient I want to highlight is the one that I needed to. This is an anoretic with total stem cell deficiency. I was just seeing if it could help her in terms of pain and the epithelial healing. It did. So she had these persistent epithelial defects for over a year, and this healed her in about a month. But then a little shortly after, she did have a recurrence of epithelial defects, so I ended up doing. My backup was going to be a keratodermal allograft anyways, but I did it with a BMAC, and she's been healed and looks great for 3 to 4 months out now. And then this patient with recurrent erosions is now 10 months out, and instead of weekly erosions, she's been erosion free for the last 10 months. I do want to highlight Dr. Ho's Aniridia pilot clinical trial that he's been conducting with BMAC as well. So far, he's enrolled 13 eyes. In terms of inclusion, they were looking for patients with partial stem cell deficiency, with about a quarter of the limbus that's been that's still intact, or if there's no no stem cells, so near total or total limbal stem cell deficiency. Those that were included were those with persistent epithelial defect or recurrent erosions. They included patients that were 2200 or worse and only treated one eye with the BMAC in their worst eye. There's been, in terms of interim data to date, there's been no infectious complications. All eyes epithelialized by about 1 month postoperatively, and there's been improvement in the mean vision at the post-op month 3 visit. A nice finding that he saw was that these superficial vessels that are often associated with limbal stem cell deficiency, he hasn't seen any recurrence in the central 3 millimeters at post-op month 3. So I want to go through a procedure video, and then we'll do a live demonstration here. But just sort of image-wise, what to expect. So on the far top left, this is the tissue that you'll get as it's prepared for you when you receive it. So the tissue is stained. It's essentially similar to a DMEC prep that they've nicely taken off this endothelial cells. There's an S stamp, and the S stamp is near the hinge. You'll do then you tree find with the S stamp essentially at the border of your tree find, so you don't get the hinge. Perform a superficial keratectomy. Make sure the surface is dried for a couple minutes. Then you'll place the corneal button on the surface. I would weck within the interface. That allows the BMAC membrane to stick a little better. And then you can peel off the overlying stromal button. And then the goal is to smooth it out with cannulas or your preference. And then you can use to secure it. You can use small amounts of fiber glue at its edges, and then place a bandaged contact lens in place for security. Sometimes, the graft might have some folds or might be stained as well, just in transport. So just want to show a couple examples of how to manage that. So here's an example with poor tripan stain, some folded edges. Here I'll first put some saline on to see if it'll unscroll it. I ended up putting in the tripan for about 30 seconds or so. I use Wex on either side to help take the tripan out. Add some BSS, and you can try and unscroll it with your cannula. Sometimes what works better is just by capillary reaction, taking 2 Wex on either side and just get in the interface. And also you can take a cannula, BSS cannula, and come underneath. This one was dislocated off to the side, so attached with the hinge and poorly stained. So add tripan and then add some BSS, and then just come underneath with your cannula and help just float the membrane back into position. And again, use some Wex on the other side and try and draw out the fluid to help flatten it out. And then you're ready to trephinate. So this is a patient example, limbal stem cell deficiency, secondary to contact lens, history also of neurotrophic keratopathy and a corneal scar. So first we'll start with your typical keratectomy. I like to use a took knife just because it's blunt, but you also see me there's a fibrovascular pannus, so I'll elevate that and then peel that away. I also use some Vanna scissors as it gets close to the conjunctiva. I like to confirm my measurements. You want to use about 0.5 edge around there between the epithelium and the graft. Then we're flattening out the graft, drawing out fluid. We'll punch. I have this button, and we'll place this on the dried surface. Weck to keep the graft sticking, and then peel it off. And then using cannula to help smooth out the graft. If there is an area that has some wrinkles, like here, I can add a little fluid. It curls up a little, then flatten it back down by drying it as well. Sort of a combination of those things. And you can use a pretty good amount of posterior pressure, downward pressure to squeegee out the interface fluid. I think this is the most important part. But it looks really nice after you have it. And then small amounts of fiber glue to cover the area. And then we'll place a bandage contact lens afterwards. So let this dry I let it dry for 5 minutes or so, and then we'll place a bandage contact lens and give some injections of antibiotics and steroids. Very good. So we're gonna, just in summary, this is a novel graft technique, able to add something to your toolkit for these tough eyes with bad surface issues. Can promote corneal epithelial regeneration, optimizing limbal stem cell growth. It's optically clear, which is a nice benefit over some of the other options you have, like amniotic membrane. It's more durable and resistant to degradation than the alternatives. The preclinical data shows stem cell and epithelial support, as well as protection of the stromal from stromal melting. And some early clinical data shows epithelialization without any serious tissue-related adverse reactions. So, I'll move over here and then forward where the hinge is at, usually where the S stamp is at. So, let's maybe move this out of this side for a little bit. Great, so the hinge is going to be where the S stamp is. So we'll actually grab over here and make sure because so if fluid runs down, it won't curl back up with the fluid, right? So I put it in the well here. Is that better? I'll use a Weck here again to help draw flatten the graft. Just for demonstration here, we'll use some tripan. I like to let that steam for about 30 seconds or so. I think that's enough. Take 2 wecks on either side. It draws out the fluid equally from both sides. So there's always a little stain there, so I don't think it needs maybe up the full amount here. Like I said, we know where the S stamp is, and so try and position that so you can go at the edge of your trephination. So we use vacuum here, get suction. You can use forceps, but very gently if you need to position the grab. I like to use weck cells here. Okay. I move this just a little more. I normally use a Baron Trefine, Baron Hesburgh. So. And we've already prepared the donor or the recipient here, so I move that into place. I've also marked my 8 millimeters. As we mentioned, you want to do your superficial keratectomy to at least have a border of about, so when it clears them, about half a millimeter. I like to use a wet weck just to get debris and epithelium off at the end. Do you have scissors? Do you have a?
Yeah.
So here we have obviously a tag of stromal tissue. So I want to get rid of that. So on our dry surface, we'll place the graft, center it on our I think we lost part of our from the trephination. So we'll see how that looks afterwards. We'll have to deal with that. We work the interface fluid here. Usually let it sit for about a minute. Sometimes you can move it to get an idea if it's going to stick or not. Then I'll basically use this. Can't let it get it to. And if I need to move it, you can put some fluid underneath. That's, you can see that that side is curling up, so I would take. And the goal is to get this to lay flat, so I'll use some fluid every once in a while. You can see how it helps it unwrinkle. Some of them come out really nice, or just come out right from the beginning, and are easy to. Some of them just take a little time. Just take a little time to work. There we go. I haven't had a graft tear at all. Just something to work through. I think it was from the trephination was a little, might have caused a tag there. Right. I'm a little picky on the edges, make sure everything. There we go. Make sure everything's unflapped. So that way the epithelium can grow nicely over it and not grow under it. Okay, perfect. So that's in focus for you. So you can nicely see the S-step and it'll be in the right orientation. Once you have that, then we let it dry for about at least 2 minutes, and then place tissue glue and just a couple of dots here, and then we'll spread it around. Let's just secure the edges.
That's a tissue glue?
Yeah. Yep. Yeah. So fibrin and then drum and yeah. But since you just want a very thin layer there, and then you put the second agent there. Let it sit for about 5 minutes, then bandage contact lens. Depends on what you're doing it, what other procedures you're doing it with. Some of the doctors are doing this under topical anesthesia. Some are doing it with under block. But overall, it's a pretty simple procedure that, like I said, is maybe a great thing to add to your toolbox. So I'm happy to take any questions, obviously.
So, I don't know. There's no microphone, is there?
Yeah, can you hear me?
Yeah, I can hear you.
Oh, okay.
Can you hear me?
Yeah.
Oh, okay. So you can do it partially too, right? You don't have to do it.
No. Okay, you definitely don't need to do that much. So I have some where if there's only a defect that's only a couple millimeters, I just go a little bit bigger than that.
Right.
Yeah. So exactly. So I've done some that I use just a dermal punch, and use that. Yeah. I've used it in some one really bad neurotrophic patient as well. So I was able to get him to heal within like 2 or 3 weeks. So, but it's pretty elegant. In terms of the procedure, it always looks pretty good. One thing that Dr. Ho has been telling me afterwards, occasionally I would, even though it's super smooth right here, I might see like a wrinkle, and it's obviously because maybe the blinking. So some tips he's